All right, so good afternoon, everyone, and thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. Today's webinar is with Dr. Goltz, our shoulder and elbow surgeon. Dr. Goltz's office locations are at Lake Nona and Innovation Tower, and the topic that he will be covering this afternoon is helping your shoulder pain, rotator cuff rehab, and treatment. So just a few quick notes. At the bottom of your screen, you'll see the Q&A icon where you can enter as many questions you may have throughout the presentation, and Dr. Goltz will have time at the end to answer as many as he can. And also in the chat box, I will share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance that you may need. This webinar is being recorded, and you will all be emailed a recording within a few days. So without further delay, I'll pass it off to Dr. Goltz. Welcome, Dr. Goltz, and thank you for your time this afternoon.
Appreciate it. Thank you, everyone, for joining. I'm really looking forward to this. I am a fellowship-trained orthopedic surgeon specializing in shoulder and elbow preservation and joint reconstruction, and looking forward to telling you a little bit about how to protect your rotator cuff, rehab and treatment. And this is a talk that actually, there's many talks out there on rotator cuff surgery that you can find, rotator cuff like operative treatments, but the goal of this talk is actually going to be, number one, protecting your rotator cuff, so prevention through rehab, but also a little bit about how we decide whether or not to treat your rotator cuff and how to treat it. And so that'll be kind of the goals of the talk here. So this is actually part 2 in a 2-part series on shoulder pain. So the first part was actually on shoulder replacement, so degenerative conditions of the shoulder that result in needing to actually have a shoulder arthroplasty done, and that is on YouTube available for you, so you can just look that up and get some more information if you're interested in learning about shoulder replacement. This is part 2 that's on rotator cuff issues. So we'll go through this is just a brief outline. We'll go through an introduction, talk a little bit about what I do, and then there's very brief anatomy that's important to know about the shoulder. I promise I'll keep it high level and we won't go into too much detail, but there are a few things that you need to understand and be able to kind of differentiate. And so we'll go through very brief anatomy. We'll also talk about conditioning and prevention, and then very briefly we'll touch on treatment, especially the decision about whether or not to undergo surgery, and then we'll touch on surgery as well. All right. So just by way of introduction, and I talked a little bit about this last time in the part 1 talk, Rothman Orthopaedics was founded by Richard Rothman back in 1970, and his big innovation was having a subspecialty focus with the surgeons that are part of the practice, so that you know that if you have hip pain, you're going to be seen by a hip specialist, or a shoulder pain, you'll be seen by a shoulder specialist, and you can be confident that when you see them that they have deep expertise in the area that you're being seen for. And so he really prioritized that subspecialty focus and a real focus on the community and having the patient and their outcome as the absolute priority. So that's a little bit about us. What about me? So again, I'm a beginning to end shoulder and elbow surgeon for adults and adolescents. So I take care of young people that may have some shoulder instability. In the last talk, we talked about in older patients, wear and tear disease like arthritis or rotator cuff arthropathy. I take care of everything in and around the elbow. And then in middle-aged patients, the topic of this talk is tendon injuries, and that includes the rotator cuff tendons. And it's a big topic, but it's one that we will tackle here today. So just very basic, brief, high-level anatomy. It's important to understand the rotator cuff and what it is. So the rotator cuff is a set of 4 muscles that cross the shoulder and insert at the top of the humerus through tendons. And the purpose of the rotator cuff is to raise your arm in front of you with power, as well as rotating your arm at the side with power. There's 4 rotator cuff muscles and tendons. The tendon is just the terminal end of the muscle that inserts onto the bone. There's the supraspinatus on top, the infraspinatus just behind it. In the front of your shoulder, there's the subscapularis, and then in the back of your shoulder is the teres minor. And this is also listed top to bottom in order of most frequently to least frequently injured. And again, the whole purpose of it is to raise the arm above you and rotate the arm at the side. All right. There's another important structure in the shoulder that is also important to understand, and that's the biceps. And everyone knows about the biceps kind of generally. It's the muscle that's kind of in your mid forearm, and it helps you to bend your elbow as well as rotate your forearm palm up. That's a really important secondary function. And the biceps muscle that you have in your mid arm is actually composed of two tendons. One of them is the short head of the biceps, and that's the one that you can see kind of on the right side of this picture coming off the coracoid process. That's part of your shoulder blade. That one is very rarely injured or painful, although there are some contexts, but it's outside the scope of this talk. The one that is frequently painful is the long head of the biceps that comes off of the socket and then makes this kind of left turn at the top of your shoulder before joining the common muscle of the biceps here. And it's this long head that's sort of a variant or an accessory head, and that's the one that can become painful. And you can see right where it enters into the groove here, you can have pain. And that's because it can be because of tearing, it can be because of inflammation. Also, the origin or the start of the long head actually is part of the labrum at the top of your socket, so that can actually cause pain as well. But the long head of your biceps is a very common pain generator. And if you look at where it anatomically is positioned in the shoulder here, it's actually right in between two of the rotator cuff tendons. And so it stands to reason that if you injure one of those two tendons, either your supraspinatus or your subscapularis, if you injure one of those or both, chances are your biceps isn't getting out unscathed either. It might be injured too. And so it's very commonly associated, although not always, with rotator cuff issues, but it can also be injured by itself through that mechanism. Another anatomic region you kind of need to understand is called the acromion. It's the bony roof of the shoulder. It's part of your shoulder blade. And right underneath it is a fluid-filled sac called your subacromial bursa. And that bursa can become inflamed and painful, particularly when you raise your arm above your shoulder. So, and then it can contact the acromion, or that bony roof of the shoulder. Next is the shoulder capsule. So there is a thick, soft tissue covering that essentially envelops the entirety of the shoulder, the glenohumeral joint, and it serves to help with stability. It helps to keep in the synovial fluid that helps to lubricate the joint. However, it can also become inflamed, and when it becomes inflamed and painful and thick, you decrease your motion, you get very stiff, and it becomes very painful, and that's called frozen shoulder colloquially. The technical term is adhesive capsulitis. But the capsule of the shoulder is a very important anatomic structure that, when working well, is very important, but when it becomes inflamed, can become very painful, and it's an important thing to differentiate when you're looking at different causes of pain in the shoulder. Finally, and we talked a little bit about this in part one of the talks, the glenohumeral joint. So your shoulder is a ball and a socket joint. The ball is the humeral head. The socket is called the glenoid. And you can see here on the left, typically you have healthy cartilage, which is the soft tissue cushion of the shoulder. However, as you have wear and tear in your shoulder joint, you can erode away some of that cartilage, and the arthritis that results can become very, very painful. And that's another thing that we have to differentiate when we're looking at your shoulder and trying to diagnose you. All right, so that's the anatomy. I promise we made it through. Hopefully everyone's still with us and not totally asleep. All right, but the reason why I brought all that up is because many people have a combination of shoulder issues present. And so my job is to sort of use detective work to ask you questions about what your pain is like, what your function's like, then do a physical exam where we go through a bunch of specialized maneuvers of your arm, and then also use imaging all together as clues to figure out, number one, what is it that's actually bothering you the most? And then of those things, what's actually potentially fixable? Like what can we actually address? And so that's the detective work that we're using as shoulder surgeons to figure that out. And so that's why it's so important to understand all of those kind of anatomic structures that we just went through. So On the right, you can see an MRI scan of the shoulder, and you can see the rotator cuff is the muscle that comes across, then becomes black tendon and inserts at the top of the humerus right there on the greater tuberosity. And it's critically important to understand the following, okay? As we all age, myself, all of you, our shoulders accumulate wear and tear. And that isn't necessarily painful. Some of it may become painful, but a lot of those wear and tear changes are what we call subclinical, so they don't actually cause symptoms. However, when you get an MRI, the radiologist may note many abnormal findings in your shoulder. So if you're 70 years old and get a shoulder MRI, don't be surprised if you have a list that's like a page and a half long of things that the radiologist is finding in your shoulder that are not normal. However, many, if not most of those, are often what we call incidental, which means that they're findings that the radiologists note, but they're not actually causing you symptoms or causing you pain. But the radiologist's job in writing their report as they read that MRI, their job is to notice everything and then write it down. And then our job as the physician, coupled with you as the patient, is to figure out what is actually important from that based on what you tell us about your symptoms, your exam, and then pair that with the imaging to figure it out. Hopefully that's a really important concept to understand. And it boils down to this whole idea of, like, as a surgeon, I treat the patient, not the imaging. I treat you in front of me, and I'm not a slave to whatever the imaging is showing. And so if there's something that's noted on the imaging, but it's not causing you any symptoms, and I don't think that it's going to progress or get worse, then it's something that we don't necessarily have to focus on. One of my mentors, I remember a quote that he would always say in clinic. He's up in Philadelphia, and the quote was, he would tell patients, shoulder pain is not a heart attack, it's not a stroke, it's not cancer, it may feel like you're dying, but it's really a quality of life issue. And so what he meant by that was the following: shoulder pain is important, and it becomes increasingly important the longer it goes on, and especially if you have an injury. But ultimately, it boils down to being a quality of life issue. And so when we're talking about timing, it's important to remember that. And then what we can do is decide on our treatment based on that and based on the urgency and the severity of your symptoms. So again, the rotator cuff is the topic of this talk. It's the focus, not the other things, although the other things are important to understand. But there's 4 rotator cuff muscles, and those are the things that we're kind of focusing on in this. Now, the first question when you come into clinic to see me, one of the first questions that I'm going to ask is, did you have an injury or did you not have an injury that you can remember? Is it a traumatic event or is this atraumatic pain? And if it was an injury, was it a recent injury or was it remote, like 5 years ago? And if there wasn't an injury you can think of, maybe it's just kind of progressive pain that's just gotten worse over time. And the reason why that question is so important is because it actually changes how we decide to treat you. So there's a few key questions that we're going to ask you when you come into clinic. So one is, where is your pain the worst? That essentially means location. So is it in front? Is it in back? Is it on the outside, kind of the lateral aspect of your shoulder? Or is it like deep in the joint and it's tough to kind of point to it because it's just like kind of right in the middle? And does that pain, is it worse somewhere and then does it radiate anywhere? Does it radiate down your arm towards your mid upper arm? What is the character of the pain? It's really important to know this. Is it a dull throbbing pain or is it a sharp stabbing pain? Is there crepitus? That's the technical term for cracking and popping in your shoulder when you're moving it. Is there neck pain? Is there pain that's shooting down your arm all the way into your hand, like an electric shock pain? Do you have weakness with overhead activity? Does it get worse at night? And the reason why all those questions are so important is because different injuries or different pathologies can present very differently. So rotator cuff pain often is present on the lateral aspect of your arm, so kind of the side of your arm, and it can radiate down to the mid humerus, the mid portion of your upper arm. It's often, although not always, causing dull or throbbing pain. Sometimes people describe it as sort of like a toothache. It's just like always there, and it's not associated with activity necessarily. It's just like this dull throbbing pain that won't go away. It's typically less frequently sharp or stabbing pain with movement. With that kind of thing, if you tell me that, it's not to say that your rotator cuff's not involved, but I'm thinking more arthritis as the cause to that pain. It can lead, so rotator cuff pain can often lead to weakness with overhead motions, often with relatively little weight. So think like lifting a dish out of a high cabinet. So you may be able to get your arm up to the high cabinet, but if you add just even a little bit of weight to it, your arm's going down. It's severe pain just because of weakness and pain. Very frequently, rotator cuff pain is worst at night. It's often at night and can even worsen at night. And quite frankly, we actually don't know why that is. We don't know why it gets worse at night, but sometimes it can, and patients will often say that. What is rotator cuff pain typically not? Is typically not shooting electric shock pain down your arm into your hand. With that type of pain, we're thinking it's coming from your neck, from a cervical nerve compression. If it's sharp pain, again, we talked a little bit about this, it may be due to arthritis. For global pain and stiffness, you're thinking adhesive capsulitis or frozen shoulder. Those are just kind of some of the buzzwords that we use in clinic. Now, this is before you have a rotator cuff injury. How can you prevent and preserve your rotator cuff? And what steps can we take? Now, if you look at this screenshot here, this is a Netter's anatomic drawing, and look at all the different muscles that you can see from someone's back that are surrounding the shoulder. And only one of these that you can see right here is part of your rotator cuff, your teres minor, you can just see peeking out here. All the rest of these muscles are also involved in your shoulder, but are not specifically your rotator cuff. There's your trapezius, your deltoid, your latissimus, your rhomboids, levator, like all of these muscles contribute to strength and stability of your shoulder. And so it's really important to focus on your entire shoulder across two important domains when you're trying to prevent rotator cuff injury. Number one is flexibility, and number two is strengthening. And so that's what we're going to talk about here today. And this isn't just coming from me. This is actually all of this stuff that we're going to be going through is based on an official rotator cuff and shoulder conditioning program that was put out by our professional societies, the American Academy of Orthopedic Surgeons and the American Shoulder and Elbow Surgeons Society. And you can go to this link, and I love this, and I'll very frequently print it out for patients that are looking to preserve their rotator cuff and strengthen their shoulder. And so we're going to go through a few of the exercises here today that focus on flexibility and then strengthening. So flexibility essentially means stretching. And first, we're going to do a light warm-up. We'd recommend just 15 minutes of light exercise like walking, jogging, elliptical. And the key point with all of these flexibility or stretching exercises is to avoid pain. Ease off if you're experiencing pain with any of these. Now, one exercise is pendulums. And so this is essentially leaning over a flat surface, letting your arm hang, and then rotating it in kind of wide circles in a relaxed way. And so what that's doing is stretching all of the heads of your deltoid, as well as all of the muscles in your rotator cuff. Then what you can do is take a stick or a bar that's maybe about 2.5 feet long, and you can use that to do passive rotation exercises. So holding it in front of your body, you can passively externally rotate by pushing one arm out to the side. That stretches your infraspinatus and teres minor. And then if you put the stick behind your back on the bottom left here, you can do passive internal rotation where you pull the other arm up your back, and that helps to stretch your supraspinatus. The sleeper stretch you see down here, that's not just for professional athletes and pitchers, although we'll frequently do it for them that have posterior capsular tightness. This is for everyone, and you can lay on your side, push your arm down to the floor, and it stretches your infraspinatus and teres minor specifically. These are just 4 of the exercises that I really like in this conditioning program. There are a bunch more, and I recommend them all, and I recommend that you go to the website and print it off for yourself so you can do these. So this is stretching. It increases flexibility, stretches the muscles, and what it does is set you up for the strengthening aspect of this. And that's what's next. So again, all of this stuff is from this conditioning program from our professional society. So for strengthening, you really just need 2 things. You can use a band that you can use to a resistance band, or you can use a 2 to 3 or 5 pounds at most weight to do some of these. So external rotation, this strengthens the back of your rotator cuff, your teres minor and infraspinatus to a certain extent, as well as your middle and posterior heads of your deltoids. So put the resistance band on a doorknob and rotate out against the resistance, or lay on your side, put a weight in your arm, rotate it out. Internal rotation. So this is strengthening your pectoralis. So again, same setup, but you're rotating against resistance towards your belly with both of these. Next is, this is probably the hardest one. This is external rotation in 90 degrees of abduction. So you're bringing your arm up here, rotating out like this. That's strengthening your posterior rotator cuff. And again, you can use a resistance band against a doorknob for that. Similar setup is actually the standing row here. So instead of doing it over your head like this, you keep your elbow close to your body and pull back. That strengthens your trapezius. And then on the left here, the trapezius raised specifically, you're leaning over a flat surface, you're raising your arm with a weight that strengthens your middle and posterior heads of your deltoid, your trapezius, as well as your superior cuff, your supraspinatus. Again, that's just a sampling of the exercise in this conditioning program. I highly recommend you look at them all and you do them all. They're great. They're endorsed by our professional societies, and I give them to patients all the time. So let's talk about imaging. So x-rays are really critical. They're helpful and they're also mandatory, and we will get them. And I always get them before we would even consider getting any advanced imaging like an MRI. However, if we, based on your symptoms and your physical exam, suspect that you have a tear based on that, and it's either a traumatic event or you've failed some conservative management, an MRI is basically required for confirming and understanding a tear that we suspect from your history and physical exam. And you can see this MRI here again. Your rotator cuff is a set of muscles that turn into tendons, insert at the top of your shoulder, the top of your humerus there. And that's what a healthy rotator cuff tendon looks like. Right there, it's inserting at the top there. It's nice and black and healthy, maybe a little bit of inflammation there, but it's pretty minor. What does a rotator cuff tendon tear look like? Well, you can see on this image on the left here, all of that white space is where the tear happened. So the tear basically means that the tendon has torn off of the top of the humerus and is right there. That's the end of it. And those tears can all have different shapes and sizes. You can see here in the middle, that tear is a bit bigger and the tendon's retracted. This image on the right, it's a much larger tear and there's a ton of retraction. So these tears can have different sizes, different amounts of retraction, different amounts of muscle atrophy and infiltration, and they can involve anywhere from 1 to 4 of the rotator cuff muscles, and all of the above inform treatment. Let's talk about tendon retraction. So why do tendons retract? So just think about it. Your muscle, your rotator cuff muscle, is innervated, or it gets its input from your brain. What your brain is telling the muscle to raise your arm. But if the tendon is torn and no longer attached to your arm, it's not going to be able to do that. But the muscle doesn't know that. And so it's going to keep pulling, and it's going to pull that tendon progressively further and further away from its origin where it tore off over time. And that's why those tendons can eventually retract further and further away until eventually they may not be able to be repaired. That's what tendon retraction is. Tears can have different sizes. They can involve multiple tendons, up to 4 tendons, or as few as 1. All of the above inform treatment. What about muscle atrophy and infiltration? What is that? So this is an important principle. So in order to fix a tear, the muscle of your rotator cuff ideally needs to have as little atrophy and fatty infiltration as possible. So let's unpack that. So look in image A here, in frame A. This is a side view, kind of looking at your shoulder from the side. And when you're looking at it from the side, the bones of your shoulder blade actually make the shape of a Y. You can see that right there. That looks like a Y. And your rotator cuff muscles essentially form a ring around it. And look in frame A here how healthy all of these rotator cuff muscles are. They're super dark. There's no light within them. They're very large. They essentially fill the entire space. And then as you move into frame B and frame C, definitely frame D, and finally frame E. Look at how small they get. Look at how much white is getting in there. What that is, the white that's infiltrating into that muscle is fat. And that's fatty infiltration that can happen. And then the muscle becomes smaller. Look at how much smaller it is in frame E than it is in A. That's what's called fatty atrophy. Why does that happen? Well, if you have a tear for a long time, we're talking, many months to years, essentially more than years, what that tendon can do is, because the muscle is no longer able to work to raise the arm, the muscle's not working at all. And so fat replaces the muscle. And it's really, when that happens, your chances of success with repairing the rotator cuff go down quickly. And having a re-tear, or even if you don't have a re-tear, the ability of that muscle to actually work and power your shoulder as it did before, go way down. And these changes, unfortunately, are irreversible when they do happen. And that's a really important principle. So let's say that you've been diagnosed with a rotator cuff tear, and you're trying to figure out how to treat it as a surgeon, as a patient. So the management of rotator cuff injuries is something where we have actually very good evidence-based clinical practice guidelines by our professional societies. And this isn't my opinion. This isn't like just what I think. These are the actual guidelines that our sports medicine society, shoulder and elbow surgeons, arthroscopy surgeons, professional societies, as well as the professional societies for physical therapists who have deep subspecialty training in how to treat rotator cuffs. They all have come together and developed these clinical practice guidelines for us. So there's very good evidence for many aspects of rotator cuff treatment. In some aspects, there's less evidence, so we rely on expert opinion. But what we're going to do is essentially go through how to treat rotator cuff injuries and tears from the perspective of these guidelines that have been laid out for us. All right? So again, going back to this first question, is it a traumatic injury or is it just atraumatic? There was no injury you can think of. So it's a traumatic injury. That's a little more straightforward. We're trending towards earlier imaging and earlier surgical counseling and consideration for those. However, it's atraumatic, it's chronic, it's just kind of progressively worsened over time. There's no injury you can think of. In those cases, simplistically, we'll try conservative management first, all right? And this is really just a question of timing, okay? So we'll start with traumatic rotator cuff tears, where there's an injury you can think of. The timing we're talking about is when to operate, when to pull the trigger. And importantly, how much conservative management do we attempt first? And the evidence, in general, is trending towards an earlier repair, operative repair for traumatic tears. And there's a few papers that have talked about this. One of them was published back in 2021, actually out of Rothman Orthopaedics in Philadelphia, the mothership. And in this paper, they had a key finding, all right? Their key finding was that for traumatic rotator cuff tears, so where there's an injury you can think of, surgery within 4 months of that injury can result in a statistically significant improvement in the patient's outcome compared to surgery more than 4 months after that injury, okay? Now, what's really important is that's a statistically significant improvement. Maybe it's not necessarily a clinical improvement that you'd be able to monitor, but they did find an improvement that reaches statistical significance. There are a few important caveats to this finding though. So number one, as we talked about before, you need minimal muscle atrophy. That's critical just across the board. Number two, you need minimal changes on x-rays. So we don't want to see much or any arthritis or humeral head elevation or arthropathy on x-rays, okay? And then whether or not to address this sooner rather than later depends on a lot of factors, including the size of the rotator cuff tear. And it's important to understand 4 months still potentially leaves some room to try conservative treatment like physical therapy if the patient desires. So let's say you're on the more risk-averse side, you're trying to avoid surgery if possible. This 4-month window gives you the opportunity to maybe try 6 weeks of PT, see if it helps, and still have the surgery within this window. So, and again, another caveat, this trend is sort of recent, and there's been subsequent work that has supported it and subsequent work that has somewhat contested this. And so it's sort of something that we're trending towards doing, but it's certainly not conclusive at this point, all right? again, this first question, traumatic or atraumatic. So that's what we do for traumatic injuries, earlier imaging and surgical consideration. What about for these chronic atraumatic tears where there's no injury? At that time, or for those types of patients, we'll try conservative treatment first. So remember, this type of pain is characterized by slowly progressive shoulder pain that worsens over months to years. There's no injury you can think of, or maybe the injury was 5 years ago and you just never had it treated or evaluated. For these types of patients, the initial treatment involves conservative management. So you're asking, well, what is conservative management? What does that mean? You're using this word. So the best options for conservative management, where there's the most evidence, are these. So activity modification. So are you working, say, at an Amazon warehouse lifting boxes over your head? Or are you able to transition to more of a desk job to try to modify your activity to place less strain on your rotator cuff? Anti-inflammatory medications form a key role here. So Tylenol especially, as well as NSAIDs, nonsteroidal anti-inflammatories, if your stomach can tolerate it. Think things like ibuprofen or naproxen. Physical therapy is a key player in this. It's so important, and very often rehab with physical therapy can really help with your pain and function. And then finally, injections of various types can also be good. So other things that people try, there's a little bit less evidence for some of these, but if it works, I'm all for it, okay? So gels like diclofenac or Voltaren gel, some people like that a lot. Pain patches like lidocaine. Many people really enjoy and benefit from acupuncture, massage, heat, cold, exercise. All of these things really important, but especially with a few of the former, like less evidence, but hey, if it works for you, I'm all for it, and I'm super supportive of it. So a lot of the work that's been done understanding how to manage these atraumatic chronic rotator cuff tears comes from the Moon Shoulder Group. And essentially, over the course of about a decade, 10 years, there has been a large randomized controlled trials looking at patients that have atraumatic, chronic, full thickness rotator cuff tears. And they are what a lot of the clinical practice guidelines are based on. And so the key findings of their work over about 10 years, by the way, their most recent study that summarizes all this stuff, hot off the press, 2024, just published a few months ago. So this is hot data. The key findings are the following. For chronic atraumatic full thickness rotator cuff tears, physical therapy is an effective treatment for over 70% of patients. And as a result, because of that physical therapy, only 25% of patients with full thickness rotator cuff tears that are chronic, only 25% eventually require surgery. And the strongest predictor of whether or not physical therapy will be successful in treating your rotator cuff tear, believe it or not, is whether or not you believe that the physical therapy is going to help you. And so the patients that do not do well with physical therapy treating their chronic rotator cuff tear are those that think, what's physical therapy going to do for me? I've got the tear. How is it going to help? Patient expectations are the biggest and strongest predictor of how successful physical therapy will be. Next is activity level and what the demand is that you're placing on your shoulder. There's a few other factors like workers' compensation status that's outside the scope of this talk. But the benefit from physical therapy in these patients, those benefits can last for up to 10 years with minimal to no decline. Again, this is a 10-year study, multi-center all across the country, and they found minimal to no decline at 10 years. So, but you should have a bunch of questions about this, right? As a patient, because you have a cuff tear. So won't my tear progress? Won't it get bigger? Won't it get worse if we don't address it? Physical therapy is not fixing my rotator cuff tear. You're absolutely right. Well, again, they looked at all of this stuff as part of this Moon multi-center shoulder study. So tears, when you have a full thickness rotator cuff tear, they get bigger in 40% of patients, but whether or not it gets bigger does not predict whether they eventually end up needing surgery. And there's no difference in progression whether you have pain or not. So let's say you don't have pain, then maybe you do get pain. That's not necessarily an indicator that your tear has progressed. They weren't able to find a relationship between those. And then if you don't have pain, and then you do later have pain, still only 28% of those patients eventually undergo surgery. And then what they found in this specific study is that your risk of your tear progressing to the point where it's no longer able to be repaired and you need a replacement, well, less than 1% of the patients in this study eventually needed a replacement at 10 years. Now, again, maybe these changes just take place over more than 10 years and so it wasn't detected, but at least over the first 10 years, less than 1% of patients needed to have a replacement as a result. So there are some issues with the work from this Moon study group. And one of those important ones is selection bias. It may be, so this is a randomized controlled trial. The patient has to decide to enroll, and it may be that some of the more severe patients with bigger tears that just definitely needed surgery just refused to enroll in the study because they were just like, I'm here, I need surgery, I don't want any part of this study. So there are potentially some selection bias issues with this. Now, what are some of the risk factors for having your tear progress? There are a few important ones. A big one is smoking. So smoking status, not just a risk factor for progression, but also re-tear rates after a repair. Smoking is one of the most important risk factors. Age is another really important risk factor. Our tendons degenerate over time. There's more muscle atrophy as we get older, and especially over age 60 is something that we look at. Larger tears, fatty infiltration, we've already talked about that. BMI is a risk factor for re-tear, but not actual outcomes, whether or not it re-tears, and diabetes is involved too. So overall, based on the results of this multi-center Moon shoulder group study, for patients that have these chronic atraumatic rotator cuff tears, the clinical practice guideline that it's based on is that physical therapy is great at improving patients that are symptomatic with full thickness rotator cuff repairs. And that's with a strong recommendation based on the evidence. So that's physical therapy. What about injections, corticosteroid injections or cortisone injections for atraumatic or chronic rotator cuff tears? And the answer to that is it depends. So one injection can be quite beneficial. Sometimes they're temporary, sometimes they're not. It's very difficult to predict who is going to benefit the most from them. Patients will ask me, how long is this going to last? I've seen it last 6 days in some patients. I've seen it last for 6 months or longer in other patients. It's very difficult to predict who's going to benefit most, but there's moderate evidence supporting the use of a single injection of corticosteroids for improvement of pain and function in shoulder patients. Now, let's talk about multiple or many cortisone injections. Now, I'm sure you've heard this, it risks rotator cuff tendon degeneration. The data isn't great, but I agree that if you get many corticosteroid injections, you are at risk for increased or progressive degeneration of your tendons more than you would be if you weren't getting the injections. However, in some older patients that are trying to prolong or postpone the time that they need surgery, that may be a reasonable trade-off. Their improved pain may be worth it because they're trying to push surgery off longer and longer. However, in younger patients, I think one injection is okay. I typically try to avoid more than one or at most 2 injections. Again, there's kind of poor evidence though that supports whether or not that it's actually the case. Again, in younger patients, 1 or at most 2 if I have to be convinced. So that's corticosteroid injections. What about hyaluronic acid or PRP injections? These are kind of a hot topic. There's some evidence in support of them, but it is mixed at best. But what we do know is it's at least not detrimental, right? And that's one of the reasons why some insurances don't cover it necessarily, is because the evidence is it's okay, but honestly, if it works for you, more power to you. Like that's totally fine, and I'm in support of that. But the recommendations are going to be limited just by their very nature. All right. So yet, after all that, the management of rotator cuff tears, surgery does well with a strong recommendation. And that's the good news right here at the bottom. For a chronic atraumatic rotator cuff tear, if you attempt non-operative management like medications, you've done a ton of physical therapy, you've done corticosteroid injections, and you're still miserable, you have unbearable symptoms, you have pain, you have weakness, you need something done, surgery works well. And that's with a strong recommendation there from the clinical practice guidelines. So we'll briefly touch on surgery. What does the surgery look like? So rotator cuff surgery typically today is arthroscopic or minimally invasive, so you're using very tiny instruments and cameras. Some surgeons still do open surgery, and that works as well. There may be some short-term benefits to doing it arthroscopically, but those kind of normalize out over time. You can see here in the picture, this is an arthroscopic view through the camera. The rotator cuff is this kind of crescent-shaped structure here. Normally, it's down on bone on the bottom here, but it's totally torn off. This is a tendon that's been prepped surgically, so it's ready to get repaired right now. And essentially what happens is you put anchors down into the bone. Those anchors have sutures coming out of them. You pass the sutures through the rotator cuff arthroscopically. Then you pull the sutures down, tension them, compress the tendon down to bone, and then secure those with a couple more anchors sometimes. And that allows your tendon, it secures your tendon down long enough for it to heal down to bone. All right. And this is what the eventual repair construct looks like through the camera. You can see that's the medial row anchors, sutures right there that we've tied knots, and then the sutures are coming across and getting anchored down by those two anchors there. All right. So that's the surgery that's involved. Again, not the focus of this talk, but I thought I'd at least mention it. So that's the surgery. What about the rehab and the recovery? And this is a really important thing to understand. So I counsel patients, the recovery following rotator cuff repair is long, it is challenging, and it requires a significant commitment from the patient, especially in terms of time, especially in terms of physical therapy. So it means 4 to 6 weeks in a sling, depending on tear size. And we get you moving at about 2 to 3 weeks, depending again on tear size and the construct. Increasing evidence has shown that earlier mobilization can be beneficial for preventing stiffness. Passive range of motion only for the first 6 weeks. So that means you're using one arm to raise your other arm. So you are not raising your arm on your own for the first 6 weeks following surgery. And then only after that do you very slowly progress your active range of motion, which essentially means doing it over your head on your own. Strengthening does not start until month 3 following a rotator cuff repair, and it progresses all the way out until month 6. So this is a huge time commitment. It's a 6-month commitment and to getting your shoulder back to where you need it. And I counsel patients, it's so important to have a commitment to physical therapy and to the therapist that you're working with. They have expertise in doing this, and they do this all the time. And so the patients that do the best, I can do a perfect surgery, but if patients are not committed to doing the rehab and the therapy, their result is not going to be what it could be. And so just prepare yourselves. The rehab and the recovery is a long one. Now, I always like to end the talk with kind of looking ahead and looking like, what is the next frontier to solve? What is the thing that I think is an important thing that we need to solve as surgeons and as physicians? And this is just my opinion, but what I think is something that we are continuing to work to solve, and we're making a lot of progress, is in a very specific type of patient. The shoulder condition that we have not yet completely solved is a very specific patient. It's patients with a very painful shoulder. They have weakness from a massive rotator cuff repair that massive rotator cuff tear that we can see on MRI. However, they have great active range of motion over their head, and they have no arthritis or arthropathy on their x-rays. In those patients, there are a lot of treatment options, but there's relatively little consensus on how to treat them. And I often tell people, when there's a lot of treatment options, that should be assigned to you. Well, maybe there's not like a home run solution for this actual problem. And some of the solutions involve maybe a partial repair. So again, you have a massive rotator cuff tear. So maybe you can repair part of it down, and those outcomes have been okay. A superior capsular reconstruction is another potential option. You see in the top left picture, so you use an allograft and you essentially reconstruct the top portion of the capsule of their shoulder to help keep the humerus down and restore the biomechanics of the shoulder. Same principle exists for the subacromial balloon. This is a fairly new treatment of the past several years where you put a fluid-filled balloon in the shoulder. Again, the whole point is to keep that head down, restore the biomechanics of the remaining rotator cuff tendons that you have. Other options, tuberoplasty, biologic tuberoplasty, where you smooth out the top portion of the humerus, the greater tuberosity there. So if it were to contact the acromion, that bony roof of the shoulder, it's not going to cause pain. And then finally, for patients that are just, the things aren't getting better with any of these treatments, you of course can do a replacement, but that's a real surgery. And so, it's something that we use as kind of the last resort for these types of patients. Excellent. Well, I really appreciate everyone joining.
Yeah, so thank you all for taking time out of your schedule to join us this afternoon. And thank you to Dr. Goltz for sharing such valuable information. I hope you all found this information extremely helpful. And if you have any questions, please email me. You will find it in the chat box and we will get back to you as soon as possible. Again, if you would like to make an appointment, please call us at 1-844-407-4070 or go to www.rothmanortho.com. Thank you.